So I'm just streaming at the moment. It just needs to connect up. Streaming at the moment. Oh, go. Right. Okay, we ready to go?
Let's do it.
Great, okay. Hi, Nick, hello. Sorry, you're muted for now. But if you do have a question, let us know. Okay, so let's just start with our second webinar. Hello, thanks all for joining. Just a few things ahead of actually beginning our webinar session. If you have a question, obviously, as you can see on the screen in front of you, there are 3 ways that you can ask a question. The first is through the participants button on your navigational panel. And here, if you are an attendee, you can click raise your hand, and that will alert me as the moderator to allow you to speak up whenever you have a question. The alternative and the preferred option is the Q&A box. So if you click this button on your navigational panel, you'll be able to type in your question as we go along. So if you have any questions throughout this session, while the speakers are presenting as well, you can type that into your Q&A box, and make sure that you do target your question to a specific speaker, because we do have 7 speakers at the moment. So just type in their name and then your question. The alternative is to use the chat room, which is generally for our troubleshooting queries. If you do have any issues with Zoom, make sure you send a question my way. So you can select from the drop-down box next to the 2 who you want to send that query to. And that's about it. So let's kick on with the actual webinar. So on to you, Sam.
Thanks, Michelle. So yes, thanks everyone for coming along today. So today we're going to keep it to, we're going to have each PhD student presenting one after the other, and we're going to hold our questions until the Q&A session at the end. Now Michelle is going to give us a little alert when you're getting towards the end of your time. So we'll try to keep things running to schedule. And so without much further ado, I'll just do a brief introduction for each person, and I'll first of all introduce Jay, who is our first PhD presenter today. So a little bit of background. Jay is a physiotherapist, and he is doing his PhD at the School of Physiotherapy and Exercise Science at Curtin University, with his PhD supervisors Peter Kent, Amity Campbell, Anne Smith, Peter O'Sullivan, and JP Caniero. So if we can go forth, Jay.
Hi, everybody. Can everyone see my slides okay there?
Not yet.
Not yet?
Are you sharing the screen?
Not sure.
Yep, so that's a green button at the bottom.
Yep, there you go.
There you go.
Sure.
Sure.
Great.
There we go.
Excellent. Okay, thank you very much, Sam. Yes, so my name's Jay. I'm enrolled as a PhD candidate at Curtin University, funded by the pre-OPUS. About 10 years ago, I completed my undergraduate degree with honours at Curtin Uni, and I've worked clinically for a few years before completing my clinical masters. And during my undergraduate studies working as a research assistant, I developed extensive experience in biomechanics using a number of different types of biomechanical devices. I went on to teach pain science, musculoskeletal physiotherapy, and orthopedics. But I'm basically just a clinician at heart, and I just want to understand my patients better, and specifically how people move and what influences their movement. My project is entitled Movement and Wearable Wireless Movement Sensors in Knee and Back Pain. And, oops, sorry. And today I'll be covering the components that relate to the CRE. I'll be discussing two studies today which are currently running. Study 1 aims to determine if inertial measurement units are able to detect clinically relevant field monitoring data in people with knee osteoarthritis. What soon became obvious when I began working as a clinician was that there was a large gap between how researchers and clinicians observe movement. We don't really know if people move the same at home as they do in a clinic environment compared to a laboratory environment. There is some evidence to say that people do move differently in the lab as they do at home. As a clinician, I believe how people move is an important modifiable factor that is related to activity limitation and pain. But surprisingly, there is very little information on how people move at home during their daily life. We don't actually know which activities people do with any accuracy, how much they do that activity, or how they actually go about doing it. We don't know how they're bending their knee in terms of joint angle, and we don't know what their muscles are doing. In research, sorry, there's a bit of delay on my computer here. In research, laboratory systems are very accurate in measuring kinematics and joint angles, such as muscle activity, but other methods are used in the clinic to estimate these parameters. For instance, Vicon is the gold standard measurement tool used in biomechanics research, but these clinical measures lack reliability and validity that laboratory-based systems provide. So in order for clinicians to measure movement objectively during consult, they would have to use expensive and cumbersome equipment, such as those found in a laboratory setting. New technology known as inertial measurement units can potentially bridge the gap between laboratory and clinical settings. These sensors can provide kinematic outputs. In other words, we can tell how much knee flexion there is, and we can differentiate if the leg is in front of the thigh, like when stepping up, or under the body, like during a sit to stand. What is great about the sensors that I'll be using is that there is also an integrated superficial EMG, allowing me to capture muscle activity around the thigh. The current body of evidence around the use of inertial measurement units has two major flaws. Most of the studies so far investigating these sensors use participants who are deemed to be healthy with no functional limitation, and most of the studies are validation studies that have been conducted in laboratory conditions. So for my first study, we're using a cross-sectional cohort study design of 50 participants with knee OA to explore if inertial measurement units are able to assist in providing clinically useful information about how these people move when they're at home. We're collecting data with the inertial measurement units in the Vicon Motion Analysis Lab for reference. The participants will be requested to perform a series of functional tasks, and the sensors will be placed on the thigh and the shank collecting bilateral kinematic and muscle activity around the knee. We'll then send the participants home with the sensors on their legs for the following 5 hours to collect data on what they're doing at home. A pattern matching program will be created to identify which activities the participants are doing during their field monitoring period. Take, for example, gait. Using the pattern identification program, we'll know this individual's movement signature of gait based off the laboratory data collection. We'll then have data from the field monitoring period over 5 hours, and then we'll use the program to look in the home monitoring data to find this pattern of movement. My second study is one project within the CRE OPUS multiple single case series, which is part of Work Plan 3, Alternative Therapies. The strength of the experimental single case series is its high internal validity, which is useful for generating hypotheses of causal mechanisms in a heterogeneous population such as those with knee OA. The internal validity comes from the repeated measures over the 3 phases of baseline, intervention, and washout. So if a participant's outcomes change, we can be more certain it is due to the intervention. Participants will be included based on Michelle Dowsey's 2016 publication, which reported on a prognostic nomogram, which can be used to predict the probability of non-response to total knee replacement at 1 year post-surgery. Factors included in this nomogram include obesity, high levels of poor mental health, low levels of disability on the WOMAC, and a Kellgren-Lawrence grades of 1 to 3. We're exploring the efficacy of a physiotherapy intervention known as cognitive functional therapy in people with knee OA. CFT is a model of individualized care that effectively targets modifiable physical factors such as maladaptive movement, lifestyle factors such as physical activity and sleep, as well as psychological factors such as fear avoidance and confidence. This approach has been tested in a non-specific persistent low back pain population in an RCT. RCTs in the low back pain intervention studies generally report modest effect sizes, while the CFT approach has a standardized mean difference of between 0.8 and 1 compared to best practice manual therapy. We believe that low back pain and NEOA share some similar modifiable risk factors which are amenable to this type of care. The approach incorporates a graded exposure to movement behavior, engaging patients in movement experiments to normalize their maladaptive movement and eventually integrate it into a healthy lifestyle. The second intervention is known as Shrink Plus. We know that if people with NEOA lose 10% of their body weight, there is a 50% reduction in their pain. This is likely due to a shift in pro-inflammatory cytokines. Shrink Plus is a CBT intervention that explores cognitions, mood, triggers, behaviors, and relapse as it relates to overeating or eating unhealthy foods. My project in the single case series in the multiple single case series will investigate if inertial measurement units are able to detect a change in movement quality and if it co-occurs with a change in pain-related activity limitation or pain intensity, and if they can detect a change in movement quality generalizes into field monitoring. So if we can change movement in the clinic, that is great. But what happens when a person with NEOA goes home after physio? Does the change in movement generalize into their ADLs? While lab-based studies have investigated a change in kinematics and muscle activity that occurred due to an intervention, no studies have investigated a change in movement at an individual participant level in an entirely clinically based scenario. These inertial measurement units seem the ideal tool to be able to measure this in a clinical setting. As part of the case series, we are collecting data on 3 common physical activities of gait, sit to stand, and negotiating stairs to explore if we can change movement and if the change can be detected with these inertial measurement units. We will analyze the change in kinematic output, such as kinematic outputs such as thigh and shank inclination, sagittal plane range of movement, time spent per quartile of available knee movement, and angular velocity around the knee. We're also collecting EMG of the hamstring and quadriceps, allowing us to determine if there's any co-contraction going on. I'm collecting weekly activity limitation and pain measures over the entire course of the 8-week baseline and 12-week intervention periods. For instance, one of the current participants has issues going downstairs. Over the 8 sessions of cognitive functional therapy, the physio would target this activity by changing how they think and move their knee. In clinic, movement and activity limitation and pain data will be collected at 10 time points, observed here at every data collection session. On 5 occasions over the baseline and intervention period seen here in red, we also collect field monitoring movement data. They'll then leave the in-clinic assessment and return home with the sensors on their legs and be asked to complete the functional activities at a known diarized time point. To determine the relationship of change between the outcome measures, we will visually analyze the serial measures of movement sensor data, activity limitation, and pain captured during the in-clinic sessions and plot them over time to explore the relationship of change of one variable to another. A non-parametric correlation analysis will be performed, such as simulation modeling analysis, which can statistically analyze the relationship of change between these 3 outcomes. By observing change over time of these variables, we can begin to understand the mechanisms that drive change in movement quality, activity limitation, and pain, and the relationship between these factors. These 2 studies have some broad implications for both clinicians and researchers. The case series will inform a larger multidisciplinary randomized controlled trial for people with NEOA, which targets movement, weight loss, understanding, and behavior change. Both studies I discussed today will inform clinicians and researchers on the ecological validity of inertial measurement units. And finally, these studies provide clinically useful information for both healthcare workers and about activity limitation, about activity and movement during activities of daily living. Thank you.
Wonderful, thank you very much, Jay. That was great. Okay, we're going to move straight along. So I think you should have Tara sitting next to you there. So quick introduction to Tara. Tara West is a physiotherapist as well, also conducting her PhD at the School of Physiotherapy and Exercise Science at Curtin University, with supervisors Amity Campbell, Leo Ning, Anne Smith, Peter O'Sullivan, and Peter Kent.
Got my IT guy helping me here. Is that good, Sam? Can you see that?
Yeah, that's perfect.
Okay, great. Okay, first of all, I'd just like to apologise for my voice. I wish I had a good story for you all, that I was out partying at the Melbourne Cup or something like that. So unfortunately not. I just got a cold, but I'll do my best to get through this today. Okay, so as Sam said, my name's Tara Binney, and my PhD is looking to explore the association between movement and pain-related cognitions and emotions in knee osteoarthritis. A little bit about me to start. I'm a physiotherapist. I graduated from Curtin in 2012, and I've been working in private practice and also teaching as a sessional academic at the physio school since then. And I started my PhD in February of 2017, so I'm about halfway through at the moment and right in the middle of my data collection, which is really great. So enough about me. We're all very well aware that osteoarthritis is a leading cause of pain and disability in Australian adults. And research has shown only a modest correlation between the clinical symptoms and the radiographic indicators of knee OA, which indicates that those degenerative changes alone are not responsible for all pain and disability in these individuals. More likely, it's a combination of a number of factors, and understanding the role of these factors in knee OA is important for developing successful interventions and approaches to target pain-related disability. When we talk about pain-related disability, we're referring to an individual's ability to participate in their essential life activities. And normally we measure this through self-reported questionnaires, but perhaps a better way of measuring this is by looking at an individual's movement quality, so the manner in which they perform a particular task, and their movement quantity, so how much they perform or avoid a particular task. What we often see in response to pain is that individuals may change the way in which they perform an activity. So, for example, they may adopt strategies to avoid loading their painful limb, or they may adopt protective strategies such as co-contraction or muscle guarding, or they may limit or avoid the activity altogether. So we know that there are a number of factors that influence pain-related disability in individuals with knee OA, but what we don't know much about is the impact of pain-related cognitions and emotions on pain-related disability in this population. If we take a bit of a sidestep and we look at low back pain, pain-related cognitions and emotions are well studied, and they have been shown to influence behavioural responses to pain, such as avoidance of functional tasks or physical activity, and also adopting protective muscle guarding during these tasks as well. And it's these behaviours that are thought to contribute or lead to a vicious cycle of distress and disability. Sorry. Now, given the strong association in the back, it's plausible that a similar association also exists in the knee. And if we can understand this link between cognitions, emotions, and movement, it'll assist in the development of interventions that jointly target cognitions, emotions, and movement, and in turn, hopefully lead to better disability and pain and disability outcomes in the future. So I said we don't know much about the relationship between cognitions, emotions, and disability in the OA, but what do we know? Well, pain catastrophizing has been linked to slower gait speeds and greater self-reported disability. And similarly, fear avoidance beliefs are strongly associated with worse self-reported disability in this population. And then we have knee confidence. So knee confidence is really interesting because up to 99% of individuals with knee OA will report reduced knee confidence. And while the link between reduced knee confidence and pain levels has been established, there's limited and conflicting evidence surrounding the association between knee confidence and function in this population. Now, at the moment, confidence is being assessed using a single item measure from the OPUS questionnaire, and that's how much are you troubled with lack of confidence in your knee. And it's likely that this single item measure does not provide an accurate assessment of an individual's confidence in performing a number of different tasks in a variety of different settings. And perhaps that kind of helps to explain some of the inconsistencies that we do see in this research, in that association between confidence and function. I'd also like to point out that the studies that I've talked about above, they've all focused on self-reported measures of function or on performance-based functional outcomes. And to date, the nature of these behavioural responses to pain, so the movement quality and the movement quantity, have not been well explored. So just in summary, so we have growing evidence that with people in musculoskeletal pain, that their cognitions and emotions influence their responses to pain in terms of their movement quality and quantity. If we can understand that link in the knee, it will help assist in developing interventions that will jointly target cognitions, emotions, and movement, which in turn may hopefully lead to some better long-term outcomes for these population. But before we can do that, we do need a valid and reliable way of measuring movement quality and pain-related disability in the clinical environment, as Jay mentioned before. And that brings me to my PhD. So my PhD will encompass 3 studies. The first study looks to assess the utility of an inertial measurement unit system in measuring movement quality in individuals with NEOA. The second study will explore the association between pain-related cognitions, emotions, and movement quality and quantity in individuals with NEOA. And the third study will examine how pain-related cognitions and movement quality and quantity change over time relative to each other in individuals with NEOA undergoing a cognitive functional therapy intervention. So study 1 and 2 are cross-sectional studies, and they will involve a shared single data collection session at the Curtin University Motion Analysis Laboratory. We're trying to recruit 50 participants with a clinical diagnosis of NEOA that also have a moderate to severe level of pain-related disability. Study 3 is a sub-study embedded in the multiple single case series study that Jay's just spoken about earlier. I'll speak very briefly about study 1. So study 1, as I said, is going to assess the validity of the IMU system in measuring movement quality, specifically lower limb kinematics in individuals with NEOA. So we'll have our 50 participants come into the lab. They'll perform a number of tasks, and the lower limb kinematic measures that we derive from the IMU data will be compared to the kinematic measures we derive from the Vicon motion analysis system, which at the moment is our gold standard system. My study 2 is a cross-sectional mixed method study, and it's designed to explore the association between cognitions, emotions, and movement in individuals with NEOA, and also to develop a better understanding of the construct of knee confidence. So the study will have a lab and a field-based quantitative component and a qualitative component. So the quantitative component aims to examine the relationships between scores on self-reported pain cognition questionnaires and movement quality and quantity in individuals with NEOA. So when the participants come into the lab, they'll begin by completing a number of questionnaires measuring relevant pain cognitions and emotions. We'll then be measuring their movement quality. So participants will be asked to perform a number of functional tasks, and standard lower limb kinematics, kinetics, EMG, and also spatiotemporal parameters will be measured. Now, as we're interested in measuring movement quality, we're specifically interested in parameters which would reflect avoidant or protective behaviours. So, for example, we're looking at knee angles during stance, knee external force moments, ground reaction forces, quads and hammy muscle activity, because that could give us an indication as to whether someone's avoiding loading their limb or co-contracting and really guarding, along with other spatiotemporal parameters such as speed of movement and also the time spent in single leg stance. We will also be sending our participants home with an Actigraph physical activity monitor, and that will be able to determine the time spent in sedentary, light, moderate and vigorous physical activity, as well as being able to differentiate between sedentary sitting and standing. So it'll give us a good overview of the individual's movement quantity across the course of a whole week. For the qualitative component, we're aiming to develop a better understanding of the construct of knee confidence and the association between confidence and movement. So we'll ask patients to think aloud as they respond to the question, how much are you troubled by lack of confidence in your knee? And we'll then debrief them on their response, with the aim being to get a better understanding of what knee confidence means to them as an individual. And finally, my study 3. So as I said, it's the sub-study that's embedded in that multiple single case series study that's evaluating the feasibility of alternative behavioural interventions, so cognitive functional therapy, for individuals with knee OA who are deemed potential candidates for a total knee replacement, but are also thought to be at high risk of a non-response. Now, my study will specifically explore how cognitions, emotions, and movement change relative to each other in the individuals undergoing this intervention. So while Jaya will be looking at much more than I will be, I'll just be looking at the pain cognition, the movement quality, and the movement quantity data obtained during that 12-week intervention period. Which brings me to results. So I have nothing to report, sadly. So as Jay mentioned, the single case series has just started, so it's up and running, which is really exciting. I'm about halfway through my data collection for study 1 and 2. So I've had 26 people through, 24 to go. I have nothing official to report, but I know I'm pushing it for time. I thought I'd just quickly share a couple of observations I've had, which I think are really interesting, just in regards to the qualitative interviewing I've been doing. This construct of knee confidence is really fascinating, and it's really interesting to see how different people read the question and how they interpret the question and how they respond to that based on their interpretation. So I'll give you 2 examples. I've had a participant come in. I've asked him the question, how much are you troubled with lack of confidence in your knee? And he's responded, not at all. And when I've gone on to probe and debrief him about this, he's reported to me that he actually does lack a lot of confidence in his knee, that he really struggles with knee confidence, but it doesn't actually bother him. He's not troubled by the fact that he doesn't have confidence in his knee. So despite not being confident, it doesn't worry him. So he selects not at all as his answer. So he's getting quite hung up on that troubled word that comes into the question. I had another participant that came in that also selected not at all and said that they had no issues with confidence whatsoever. But upon questioning, we determined that they basically eliminated any activity in their world that they weren't confident in. So they were avoiding a whole heap of things. They were avoiding stairs. They no longer went for long walks. They didn't do any more running or play any more sport. And when you asked them about them, they said, oh, God, no, I wouldn't do that. There's no way. But because they'd eliminated them from their life and they were avoiding doing them, in the activities that they were doing, they were completely confident. So they also reported that they had no issues with confidence as well, which probably isn't really true. So just 2 kind of interesting observations anyway. But yes, I'll wrap it up because I've gone a little bit over my time limit. So thank you, everyone.
I'm fascinated by those last results there. As a poly researcher, I love it. I look forward to hearing more about that. Okay, so we're moving on now to Nadia Clem, another physiotherapist at the Curtin School of Physiotherapy and Exercise Science, doing her PhD with a big supervisory team. And oh, you probably got it up there. And Smith, Peter O'Sullivan, Peter Kent, Michelle Dowsey, and myself, Sam Bunsley. All right.
Oh, that way. Can you see that okay?
That's perfect.
Yeah, cool. Thanks, Sam. So I'm Nadia. I am a PhD candidate at Curtin Uni. I've got a Bachelor of Science in Physio with honours and my honours within law in biomechanics. I'm also a private practice physio, so I deal with musculoskeletal pain disorders. I also work as a research assistant and an undergraduate tutor at Curtin, and I'm on the OPUS Education Committee. So my skills are experience as a physio, and I've got a bit of experience now in quality interviews and analysis. I've also done a systematic review, and I've got a little bit of experience with Vicon from my honours. So my PhD is trying to understand success after total knee replacement. So traditionally, we've thought success has been a combination of patient-reported outcome measures, so self-reported pain and function, in combination with patient satisfaction. So to quantify patient-reported outcome measures, we've really been using the WOMAC. So the WOMAC is self-reported pain, function and stiffness, and we compare this pre-surgery to 12 months post-surgery, and we're looking at the difference in those outcomes there. And the difference is then applied to an OMRACT-ORSI criteria, which determines if a person has responded or not responded to a total knee replacement. So unfortunately, we don't really understand what this is measuring, and we don't know if this really reflects what the individual thinks of their outcome, whether they think it's been successful, and we don't know if this aligns with satisfaction either. So then when we look at patient satisfaction, satisfaction is actually really poorly theorised. There's a lot of different models out there to try and explain satisfaction. The most popular theory would be fulfilment of expectations, but this has been shown to be quite flawed. So it kind of assumes that deviation from the desired expectation will equate to dissatisfaction, but that's often not the case at all. So a lot of these theories have roots in the market research, which does that really apply to a healthcare setting? We're not sure. So we don't really understand what we're measuring. We don't know how to measure it because it's been measured in so many different ways across the literature too. So this brings me to my PhD design. So it's broadly 2 studies. So we have a systematic review, which is then going to inform study 2, which is mixed methods and involves my qualitative research and my quantitative research, which will then be combined to create a mixed methods study as well. Today, I'm just going to be talking about my systematic review and my quali research because that's what I'm up to, and I've got some results for that. And we'll start with the review. So our aims were to investigate how satisfaction is measured after TKR across the literature and to explore how satisfied individuals are. So we searched 4 key databases with our keywords there and then uploaded about 3,000 articles onto Covenants. We screened the titles and abstracts in full text and then did a risk of bias assessment. We extracted from the remaining articles and put them through a meta-analysis. So we had 44 papers included in the review, and it showed really high heterogeneity, and this was mostly due to the fact that every study seemed to use a different way to measure satisfaction, which caused a bit of a problem for us because we couldn't really put that through a meta-analysis if they're all different measures. So to deal with that, we created 10 overarching groups or aspects of satisfaction. You can see from the first dot point there, all those aspects have the term satisfaction in it. And the second dot point are kind of things that are being theorised to equate to satisfaction. So that fulfilment of expectations, would recommend to a friend and would undergo the operation again. So across those 44 papers, we had satisfaction as high as 99% and as low as 36%. So a lot of difference there and a lot of different ways of quantifying these values as well. So what does this mean? It seems that satisfaction is quite dependent on what's being asked of the person. And we don't really understand how these individuals are deciding how satisfied they are either. So this really points to a lack of content validity, which means that sort of clinicians and researchers are getting together and formulating these satisfaction questions, but not testing it on an actual patient. So we don't know what it means or how they're interpreting the question. So we don't actually know if satisfaction is the right question to ask these patients. So we're almost finished with this review, and I hope to have it done by December and submit it to clinical orthopaedic related research, and hopefully they accept. So I'll now talk about my qualitative research. So the aims were to explore the factors that shape the understanding and level of satisfaction in people after TKR, and to investigate how levels of satisfaction in a self-reported questionnaire relate to perceptions of surgical success. So if we think back to the beginning of the presentation, I talked about how people are either a responder or a non-responder and how they would be satisfied or dissatisfied. So this gives us 4 key outcomes after knee replacement. So we have a non-responder who's dissatisfied, a non-responder who is satisfied, a responder who's dissatisfied, and a responder who is satisfied. And so we've been pulling these individuals out from the SMART registry at St Vincent's, and we've been aiming to get about 10 from each of these groups. At the moment, I'm lacking a few in the non-responders, so we're still collecting from those 2 groups through the SMART registry. You can see I've oversampled in the responder dissatisfied group, and that was because we were lacking some saturation of themes there, but we've got on top of it now, so we're done with that group. So in terms of the findings, obviously I'm still working on it, so I need to finish data collection, but we have a few emerging themes coming through. So first of all, the group that was a responder and who was satisfied seems to be quite consistent. They agree that they had a successful outcome and they're all satisfied. The other three groups get a little bit more interesting. They don't all agree with the categorisation of responders. So for example, some people are classified as a responder because of that WOMAC score. However, they would say that they don't believe it had a successful outcome. And this might be linked to the fact that their pain and function is quite contextual and individualistic. So it's linked to maybe more important activities to the individual. Satisfaction is also shown to be quite dynamic and changeable. So I'll look at the SMART registry and go, okay, that person has indicated that they're dissatisfied at 12 months. I'll ring them up for an interview 3 months later and suddenly they're satisfied. So it's quite changeable. And this is kind of looking like it's linked to variables such as socio-structural factors, comorbidities, and their understanding of their symptoms and the role of like the unexpected outcomes. So things they didn't even consider would happen. I have a bit of an example quote from my second participant, Lynn, on the left here. And she walked in looking like this lady. She had a forward walker. She had her daughter-in-law with her. With my physio hat on, I would say that she was quite disabled. I probably wasn't feeling very confident that she would even make it to the interview room when we were walking up. But she was very satisfied. So I have a quote from her here when I asked her what she was expecting. And she said, to walk properly, which I can, free of pain. Well, I am free of pain now. It's not a big thing. It's not like it used to be. They said the more you walk, the pain will go. And some people sit around feeling sorry for themselves. I don't. I just get up and start walking. So despite the fact that she was classified as a non-responder, she felt that she had a very successful outcome and she was very satisfied. And you can see in terms of her symptoms, her understanding of them was that they were quite non-threatening. And so she wasn't fearful of the pain. And she also seemed to have quite good self-efficacy and felt like she could take control of movement and getting on top of her symptoms and believe that exercise was the way to do this. So another finding we had was something that we didn't really set out to find from the quality interviews, but it was this concept of mythbusters. So it's all these incorrect beliefs that came out. So I think one that came out in every single interview was the notion that once you have knee OA, there is no other option than to have a total knee replacement. A few people thought you could get an infection in your knee replacement from moving the wrong way. Many people thought running and golf were really bad for your knees. Other people believed that they had a bad outcome because the surgeon probably put extra bits of metal in their leg without their knowledge. Pretty much everyone thought that kneeling would damage the knee replacements. A lot of people believed that twisting movements were really bad for a knee replacement and might put it out of place. And another popular belief was that a knee replacement only lasts 10 years. And after 10 years, you have to get a new one put in. So that's all I've got so far. Thank you very much.
Wonderful. Thank you, Nadia. Okay, we are now moving on to Michelle Chu. Michelle has a background in pharmacy and she is doing her PhD at the Health Economics Unit at the Melbourne School of Population and Global Health with her supervisors Kim Daziel, Philip Clark, Michelle Dalsey, Peter Chung, and Karen Bursky. That's good, Michelle.
Hi, everyone. Can you see my screen all right?
Yes.
Okay, great. So hi, everyone. I'm Michelle Chu. I'm a PhD candidate that's based in the Health Economics Unit at the Melbourne School of Population and Global Health. So just a little bit about me, as Sam has said, I'm a pharmacy, I have a background in pharmacy and I've been working in the Health Economics Unit for about 3 years now in research, in a research assistant role. And over the last few years, I've been working on sort of like various costing analysis in which we sort of like analyze costs associated with cesarean section in overweight women and in the Royal Women's Hospital, and also sort of analyzing the cost of implementing a sepsis pathway protocol in the Peter Mac Hospital. So my PhD thesis is titled Advancing Health Economic Evaluation Methodologies for Health Policy Design. I'm presented with quite a unique opportunity in which I'm supported by 2 CREs and to work across two quite important areas of research, which are infections in cancer and orthopedic surgery, from which I will use as my case studies to understand and examine the impact of economic evaluation methodologies. So I'm supported by an incredible team from the Center for Health Policy at the Melbourne School of Population and Global Health. I've got Associate Professor Kim Dalziel and Professor Philip Clark, who are health economists and act as my supervisors. And as I've mentioned, I've worked across 2 CREs. So one is OPUS, where I have Associate Professor Michelle Dazi and Professor Peter Chong as my supervisors and advisory committee member. And the NCIC, which is the National Center for Infections in Cancer, where I have Professor Karen Tasky also as my supervisor. So just a very brief and quick introduction of what is economic evaluation. So economic evaluation involves the comparison of 2 or more health interventions or strategies in terms of both costs and outcomes, and encapsulates this in a single measure, which will help inform us on how best to allocate limited funds to maximize population health gains. So this single measure, which combines costs and outcomes, is what we refer to as the incremental cost effectiveness ratio, the ICER, which is derived using this equation that you see on the screen. So this equation seems simple, but to come up with a cost value, there are numerous things that we need to think about. For example, from whose perspective should we be looking at? How should costs be collected and where should they be sourced from? How might we analyze costs given the skewed nature of the data? Likewise, for outcomes, we might need to think about how are we going to capture quality of life, what sort of instruments to use, and how might we would need to think about outcomes that are collected in our study and how this can translate into long-term outcomes. So this would require extrapolation or modeling, and we probably would need to think about what's the best modeling technique for the purpose of our question. So my PhD research focuses on methodologies in conducting economic evaluation. The objective of my research is to understand and contribute to the methodological rigor in the conduct of cost effectiveness analysis, particularly in the methods of extrapolation. So why is this important? Given the increasing prominent role of cost effectiveness analysis have played in health policy decision-making, I guess it's important that methods conducting these analyses are continuously refined and a much better understanding of the consequences from inconsistent methodologies is required. Evaluations of interventions need to provide useful and reliable information for policymakers and clinicians, so these people can rely on these to make important decisions and to determine the best value of care. To achieve this, methodological guidelines need to be followed and methods that we use need to be rigorous and consistent. So it is, and also it's often required that evidence of benefits in terms of clinical effectiveness and cost are provided over a sufficiently long time horizon to make policy decisions. So over the last year and a half, I've spent most of my time working on 2 main case studies, each representing an important component of the economic evaluation. So in this webinar, I'll focus on the case study that's relevant to this, which is on the extrapolation of outcomes. So quality of life instruments are commonly used in health economics research and are increasingly used in the clinical evaluation of patients. So in the last decade, we have seen an increasing number of studies that have shown that quality of life is an important predictor of mortality in chronic diseases such as diabetes and also in the general population. So there is evidence to suggest that patients with low quality of life are generally associated with a reduced life expectancy. In this example here that you see on the screen, which is taken from medical care, which assesses quality of life scores in predicting outcomes in in type 2 diabetes patients in complications such as diabetic complication and all-cause mortality. So patients were split into 3 groups based on their quality of life scores. So as we can see here, patients who report lower quality of life scores, the dotted line on the top, were at increased risk of having these events compared to those that report full health, which is the solid lines at the bottom. So this was statistically significant across all the 3 different outcomes. So this is the case study that I'm working on, which is understanding if, does quality of life matter when we're estimating survival? So in most cost effectiveness analysis, it is common to extrapolate outcomes to such as survival, further into the future to capture the full effects of the intervention. So we set out to investigate the correlation between quality of life and survival. And we're interested to know that if quality of life is an important predictor of outcomes, what are the implications for cost effectiveness analysis if we do and do not take this into account? So this study is based on a cohort of patients that have undergone elective total knee replacement. Data for this cohort was extracted from the SMART registry at St. Vincent's Hospital. So we use this as an example to understand how baseline pre-surgery quality of life and change in quality of life 12 months after surgery can impact on patients' mortality. So to demonstrate the impact of quality of life or mortality risk, survival models were developed to assess this. Survival functions from these models were then used to estimate life expectancy, calculate QALYs, and ISA. In the interest of time, I won't go through the specifics. Just a quick summary of the main findings. So accounting for change in quality of life, or both baseline and quality, both baseline of quality of life and change in quality of life, which is models 3 and 4, you can see on the screen there, compared to a reference model from when we don't take into account quality of life at all, we see small but statistically significant differences in ISA. So I guess the results indicate that the correlation between quality of life and mortality can influence cost effectiveness results, but the effects are small at the population level, as in an example here. However, there could be interventions whose ISA may sit at the threshold for funding or reimbursements, where this 9% difference can be important. We also find that there is a clear and strong relationship between baseline quality of life and subsequent quality of life. And the assumptions made regarding this correlation can potentially be important when we extrapolate and when we want to understand the cost effectiveness of certain population groups, for example, those aged 80 and above. So this gives rise to quite a number of important questions, such as if there is potential to identify groups for which surgery is cost effective based on quality of life and age and not just based on age alone? Or could there be a potential to use patient-reported outcomes prompts, for example, in using these measures to screen eligible patients suitable for surgery based on cost effectiveness? So the next couple of slides are just sort of like work in progress, which is just more research on quality of life using SMART data from SMART registry. So this analysis utilizes multi-level modeling to analyze the patterns of quality of life over 1 to 5 years post-surgery. And the comparisons were made between patients with diabetes and no diabetes, and also split out by sex. So in general, we find that diabetic patients report lower quality of life compared to non-diabetes patients, which is the red and blue lines. The blue lines are the no diabetes patients and the red lines are the diabetes patients. And females in general were also observed to have lower quality of life compared to males. So I guess this sort of highlights the usefulness of patient-reported outcomes in research, that to show that, you know, it's not just limited to health economics research, but we can potentially use information like that to target population groups or patient groups for further research, and also perhaps to assist clinicians in understanding patients and their outcomes. Another piece of work that is work in progress is we know that not all patients are of the average. Some do better following surgery than others. Some cost more than others due to complications or existing comorbidities. I guess the aim of this research is to identify specific or unique quality of life trajectories among patients who have undergone knee replacement surgery, and also to understand what sort of characteristics these patients have, and perhaps to identify a group for which surgery could be cost effective or not. So that's the end of my presentation. Thanks.
Wonderful, thank you, Michelle. Okay, we're going to move along. Next up is Sham. Sham has a background in biostatistics, and she's doing a PhD at the Department of Surgery at University of Melbourne with Michelle Dowsey, Joanne Mansky-Nankervis, and Patty Conyos. Now, are you there, Sham? I can't see. There we go.
Yes, can you hear me and see my slides?
Very good.
Great. Okay, so thanks, Sam. So hi everyone, I'm Sham, and my PhD is on using linked primary, secondary and tertiary care data to develop prediction models for total knee replacement surgery in patients with osteoarthritis. So it's a bit of a mouthful, but essentially I'm using linked data to develop prediction models for knee replacement surgery. So I'm based here at the University of Melbourne at the Department of Surgery. That's my primary department, and my secondary department is the Department of General Practice. My primary supervisor is Michelle Dowsey, and my secondary supervisors are Dr. Mansky-Nankervis and Paddy Chondros as well. So I started my PhD just this year in late Feb, so I'm about 8 to 9 months in now. And my background is, my original background's in mechanical engineering. I worked in that industry for about 7 years. And during that time, I wanted to do a bit more maths and was interested in applying it into an area which was probably going to be a bit more rewarding and a bit more meaningful for me. So I embarked on a Master's of Biostatistics part-time and graduated in 2015. And since then, I've been working as a biostatistician at the Department of General Practice at Melbourne Uni. So the background to my PhD is that we know that over 9% of Australians are affected by osteoarthritis, and we know that osteoarthritis is the fourth most common reason for consultation at general practice. In the last 10 years, the rate and cost of total knee replacement has risen by 38% and 29% respectively. So despite total knee replacement being a cost-effective surgery, there's still approximately 12 to 20% of patients who undergo total knee replacement surgery who do not report improvements in pain and function. So the aims of my research is to develop 2 prediction models. So for patients at age 45 years and over with osteoarthritis. And the first model is to predict total knee replacement surgery at 5 years and 10 years. And the second model is to predict non-response to total knee replacement 1 year post-surgery using the OASI criteria, responder criteria. The aim is then to convert these prediction models into nomograms, which can then be translated into web-based applications that general practitioners can use in practice at their clinic when they're consulting with patients with osteoarthritis. For those who are familiar with nomograms, essentially this is like a computational chart that allows you to determine the predicted probability, and it also allows you to visualize the contributions of each of the factors to that predicted probability. So why are we doing this? So the aim is to allow general practitioners to identify modifiable patient risk factors that can be targeted in the general practice setting to reduce the likelihood of total knee replacement in the future, as well as to reduce the likelihood of poor outcomes from the surgery. And we also want to be able to identify those who are least likely to benefit from total knee replacement so that we can offer them alternate treatment. So the expected impact, hopefully, is in the long term over time, improved patient outcomes, reduced health expenditure and resource use, hopefully decreased waiting list times, and also perhaps these models can help inform clinical guidelines around when to actually refer for total knee replacement. And because my PhD is mainly a statistical PhD, my aim is to contribute to how to use statistical methods, or specifically look at statistical methods to deal with electronic health record data. So I'll talk a bit about the data in a minute, but essentially one of the data sets I'm using uses electronic health records, which requires a certain, I guess, way of analysing the data that's perhaps different to how you would analyse data that's collected specifically for research. So the data that I'm using, one of the data sets comes from general practice, and that's the electronic health records that I was just talking about. And we're going to be linking that with the SMART registry from St Vincent's, which has data on knee replacement surgeries. So these are the 2 base data sets that we'll be linking. Some of the data in the general practice electronic health record is questionable in terms of accuracy, and there's a lot of missing data. So I'm using 2 validation data sets to validate some of this data. So I'm going to be using the National Joint Replacement Registry to validate some of the dates of knee replacement surgery in the general practice data set. And I'm also going to be using MBS and PBS data from AIHW to validate some of the prescriptions of certain types of medication that are recorded in the general practice records. So my PhD is very much a data linkage PhD, and this is the kind of process we're going to be using to link some of the data. So this data linkage process is staged. Stage 1 is where we'll be linking the general practice data set with the SMART registry and the National Joint Replacement Registry. And this data linkage will be carried out by an external data linkage service provider called BioGrid Australia. So that's stage 1. In stage 2, we will then link that whole data set with the AIHW, MBS and PBS data, and that linkage will be performed by AIHW. So with the NPS general practice data set, we have about 475,000 patients with osteoarthritis in that data set. We know with the SMART registry, we have approximately 4,000 to 5,000 total knee replacement surgeries. And with the National Joint Replacement Registry, that has all knee replacements since I think it's about 1999. So the aim is hopefully for the linked data set, we will have for my model to do with predicting total knee replacement surgery, we will use the full 475,000. For obviously my model looking at non-response to total knee replacement surgery, we'll be dealing with the 4,500 to 5,000 total knee replacement surgeries. So there's a fair bit of data in that. So how I'm going about this. So first of all, to do this requires access to the data sets and also approvals to do the actual data linkage. And this I'm finding out is actually a huge part of the PhD, which has been really interesting and a good steep learning curve for me. Data linkage in Australia obviously is actually fairly new compared to some other countries in Europe, for example. So what that means is getting access to data requires data governance agreements being signed, obviously, but also ethics approvals from each of those separate data sets to link all the data together. So currently we have access to the MPS general practice data set, and we have ethics approval from the University of Melbourne to link that data. We also have obviously access to the SMART registry, and we've got ethics approval from St Vincent's to do so. We have started the ethics approval for access to the National Joint Replacement Registry from the University of South Australia, and we're hoping to have that back by early December. And work with AIHW to do that. Linkage is in the process, and we won't probably have approval for that till February because it's quite a long process. So as I said before, the data linkage is staged. So stage 1 we're hoping will be done or will commence in early December. And then stage 2, once approval happens in February, won't likely happen until April or May, the actual stage 2 of the linkage. In terms of data cleaning, I'm currently doing that now. So I'm cleaning the SMART registry, and we were lucky enough to get a RACGP Foundation grant. So we're able to employ someone to clean the general practice data, and that's starting this month. So data linkage I just talked about. Hopefully we'll get our first stage at the start of or mid-December, and the second stage of the linkage next year. I've carried out my literature reviews looking at existing prediction models and predictive factors, as well as how to deal with using electronic health record data for model building purposes. I've just sent out a survey which some of you have actually answered, so thank you. And that survey is asking experts such as yourself about what factors you think are predictive of total knee replacement and non-response to total knee replacement. So the results of that survey will, as well as the results of my literature review, will help inform the factors that I will use to build my models. So currently I'm carrying out a review of the statistical modelling methodologies. I'm looking actually at going down the more traditional statistical modelling method as opposed to the machine learning more contemporary method, which I don't have time to go into at the moment, but if anyone's interested, happy to have a chat offline. And then early next year, I'll be looking at starting to develop the models and internally and externally validating them and then translating them into nomograms. And so my last slide, I think Michelle asked us to outline some skills that we have just to share. So if anyone needs help, we all know who to go to for different things. So these are just some of mine. Mainly it's statistical type analysis, cleaning large data sets, data management, and use of some statistical softwares. And that's all. So thank you very much for listening.
Thank you, Shams. Excellent. All right. Moving right along, we've got Jason up next. So Jason has a background in medicine, and he is doing his PhD at the University of Melbourne Department of Surgery with Peter Chung and Michelle Dowsey. Jason, that looks good. There we go. Can we hear Jason?
Hello?
Oh, there we go. Perfect.
Cool. So I'm Jason. I've basically got a clinical background. I started my PhD in February this year, but prior to that, I spent 3 years working as a doctor at St. V's, the last two of which was a surgical resident, primarily in orthopedics. So it's the field that I'm interested in. And what we're looking at is essentially trying to examine, broadly speaking, the clinical outcomes and the cost effectiveness of joint replacement surgery in Australia. This project's supervised by Professor Peter Chung and Associate Professor Michelle Dowsey. Now, for a bit of context, total joint replacements, as I'm sure we're all aware, can be quite effective procedures, but not always. They do need to be performed essentially in the right patients, and we're talking patients with symptomatic end-stage osteoarthritis that have failed conservative measures. But in that regard, they are nonetheless high demand, high cost, and you've probably all seen in the news and in the press recently about the cost of the health system rising sort of at rather fast rates, more than revenue can support. And then there's questions of sort of how do we continue to fund these services? So that's where we're looking at sort of the demand and the cost of performing these procedures. But what does that actually translate to? Well, first thing to note is these estimates exclude the private health system. And the reason why I mention that is electively more than half of all hip and knee replacement surgeries are done in the private system. And they do tend to be a bit more expensive in the private system for various reasons, including prosthesis costs and rehab, but we might not touch on that today. But essentially, in terms of primary hip replacements, about 37,000 were done last year. And this data is available from the AOA National Joint Replacement Registry, and that's available publicly. The reason why I mentioned primary total is because hip replacement surgery comes in multiple forms. People can get hemiarthroplasties, which are partial hip replacements, and they can get revision hip surgeries as well, which are much more complicated and much more expensive. And those two other procedures form roughly about 15% of the total hip replacement surgery. So this is not necessarily the full picture, but 37,000 in 2017. And the average cost of performing these was really identified in a study by Peel and a group a few years back, using a bottoms-up approach based on the SMART registry. So this is a public system. And they found that the average cost over 30 days in 2012 dollars was about 22,000 for hip replacements. Today, if we were to translate that to the data from last year, that's almost $1 billion to the economy. If you look at knee replacements, it's similar in terms of cost, but a few more were being performed last year, about 55,000, at a cost of over $1 billion. So what that means for our economy, essentially we're doing almost 100,000 primary joint replacements a year at a cost of more than $2 billion to the health system. So that's quite significant. But what does this mean for the future? Well, Ignacio and a group fairly recently actually did a fairly conservative modeling estimate, looking at the growth trends from essentially from 2013 modeling out to 2046. And they anticipated essentially a 2.5-fold rise in the rate of hip replacements and 1.5-fold rise in the rate of knee replacements, with an increased incidence rate per 100,000 of about 66% for hips and 26% for knees. In terms of numbers, what that means for us is we're going to be doing close to 200,000 joint replacements every single year in 2046. And looking at the cost, there was a paper that was done in the US a few years ago by Steiner's group that noted the price of hips and knees over a 7-year period increasing about 25%. Now that's in a different healthcare system, but with the the rate of growth of health services going beyond inflation, real growth in costs, these values are fairly conservative estimates using the 20 to 21,000. This is essentially a cost chart from their publication, and you can see that the trend line, the solid line, is essentially what the price should have been, assuming the real costs of performing the procedure were maintained. But the actual cost was greater than inflation. So you can see the projections in the line above that. That's for hip replacement, and a similar situation for knee replacement. In terms of dollars, if we were to index the cost purely to inflation and assume no real growth, we're looking at $11.5 billion a year in terms of hip and knee replacements in Australia in 2046. And again, that's a conservative estimate. Last year, in terms of our GDP in Australia, it's about $1.7 trillion. $180 billion was spent on healthcare. So that's 10% of the GDP. You can see the rough distribution between the Commonwealth, state, territory, and non-government sources. The arthroplasty program alone accounted for more than 1% of all health expenditures. That's quite significant. If we look out to 2046, again, based on those conservative estimates with no real growth and conservative estimates in terms of utilization rates, we're still looking at $5 billion, and that's assuming a 30% discount rate. So why does this all matter for us? Well, I think what's been touched on fairly recently is that healthcare resources, they're quite limited, and can't afford to fund all the services that we want indefinitely without something giving. And I think as clinicians, so we almost have a professional and ethical responsibility to really use this judiciously, because the last thing we want to do is basically spend our limited funds indiscriminately and find out that we haven't got funding to provide any more services. So the goal of our research really is to find ways to try and minimize waste, cut the costs, and ensure that the arthroplasty program we can continue to provide that sustainably into the future. So the AOA, in their research strategy, I think they've embodied that element quite importantly in terms of looking to research, outcomes-based research that's not only evidence-based, but cost-effective and sustainable. I think there's really sort of an acute awareness, especially more recently. This is becoming much more prominent in terms of a lot of the practices. So what we're trying to do with this PhD is really define the costs of performing joint replacement. And that there's different ways of looking at it in terms of cost up, in terms of bottom-up approach, and looking at different contributors. But essentially, we're going to try and identify what the average cost is in terms of the cost range, the key cost drivers, as in what contributes to the cost of performing a joint replacement, where rehab, prosthesis, length of stay, complications, and so on. But the key to this is really identifying some variations within each contributor and trying to single out and identify what the unwarranted variations are. And what that essentially means is variations in pricing and cost that we're paying that really don't have sort of proven evidence of good outcome or necessarily a change in efficacy. And in some situations, you see that prosthesis can vary by several $1,000s even within the same class. But there might be a sort of a lack of strong evidence showing efficacy or superiority of one over another. And that's certainly one area where we think of looking at, and with the goal to really minimize waste of resources in that potential area. We're going to sort of look at this in a broad setting, adjust the parameters and see how sensitive that is and how that applies, and really look at our cohort based on the SMART registry and see where that applies externally as well. And the paper that Peel Group did a few years ago did look into the external validity of sort of the SMART registry as compared to the AOA, and did find that it was, for the vast majority of the study, it was externally valid. And we're going to be looking at sort of hips and knees as separate entities because whilst they're both joint replacements, they are quite different surgeries and they do apply to essentially different patient populations. And the end goal at the end of the day is to really identify areas where there's an unwarranted variation, where we're spending a lot of money to purchase sort of no clear benefit or no clear outcomes, and trying to really rationalize and optimize this whole process. In terms of examining clinical outcomes, we're going to be sort of examining amongst different demographies. And I think, as Michelle has touched on, patients are a very heterogeneous group. Even if we're talking about knee replacements, different age groups demonstrate different levels of cost effectiveness, different levels of response. It'll be really sort of, I think, clinically useful to find out which of these groups may benefit more necessarily from joint replacements than others. And especially in the young groups where surgeons can be quite hesitant to look at doing joint replacements because of concerns, again, about revision rate and longevity. At the end of the day, what are we trying to achieve? Well, really strengthening the efficacy for joint replacement surgery in these different groups, identifying areas of waste to try and sort of minimize unwarranted variation and try and refine this process, make it either maintain or improve the benefits that patients can get from joint replacement or minimizing the cost. And at the end of the day, I think it's about ensuring that our practice is evidence-based, it's cost-effective, but also sustainable, and we can continue to actually fund these services into the future so that we don't end up having to cut down critical services that do provide, at the end of the day, a lot of patients to the benefit of the patients who do need them. So thanks for that.
Lovely, thank you, Jason. And we've got lucky last now. We've got Lyndon Hawke, who is a physiotherapist doing a PhD at the Eastern Health Allied Health Research Office at La Trobe University, with Nick Taylor, Nora Shields, Michelle Chu, and Peter Chung. So over to you, Lyndon.
Thank you very much, Sam. Hello, everybody. It's a pleasure to be here. Here we go. Well, as you said, my name is Lyndon Hawke, and I'm a PhD candidate and my PhD topic is looking at improving physical activity after hip and knee joint replacement. And I've been working as a physiotherapist in the community rehabilitation area for almost 20 years now, and I'm really interested in improving patient care and outcomes in the community rehabilitation space. Now, I was surprised a few years ago when a colleague of mine highlighted evidence that people who had had a hip or a knee joint replacement did not become more active after their surgery. And I actually took this quite personally. And of course they became more active because I was rehabbing them. And then I attended a lecture by Paula Harding, who's a physiotherapist here in Melbourne, and she'd done a study that showed exactly the same thing. So this is where the evidence is pointing, that physical activity after hip or knee joint replacement remains low. And by low, we mean that they do not meet physical activity guidelines, which is 150 minutes of moderate to vigorous physical activity per week. So let's back up a little bit here and have a look at the background of this particular scenario. It's been identified that people with hip or knee osteoarthritis actually die younger, on average around about 10 years younger than the average population. And a paper by Neusch in 2011 found that for people with hip or knee OA, excess mortality was observed for all disease-specific causes of death, but was particularly pronounced for cardiovascular and dementia-associated mortality. Also, the more severe the walking disability, the higher was the risk of death. This study advocated that patients with OA and a walking disability focus on effective treatment of cardiovascular risk factors and comorbidities, as well as increasing physical activity. So basically, in a nutshell, people with lower limb OA are dying younger because they're not moving as much as they should. So surely the answer is to have joint replacement surgery and to have that painful arthritic joint removed. And it's been shown that joint replacement surgery, in a lot of cases, improves function and reduces pain. And I think there's been an assumption of that by therapists that once the arthritic joint has been replaced, people would just naturally start to move more. But as I discovered, that assumption is not correct. So what is the evidence? There's been quite a few studies actually just recently and 2 literature reviews that have found that people do not increase physical activity after their joint replacement, i.e. they're not moving around, spending time moving around as much. One study found, in fact, that low activity continued up to 4 years after surgery. So the outcome of this is that people who have had a hip or knee joint replacement remain at risk of early mortality because they are not moving enough to counteract the risks of a sedentary lifestyle. It's also becoming apparent that function and pain are related more to the state of the hip or the knee than rather than something else. Oh, hang on, sorry, I lost my place. It's become apparent that function and pain are related more to a state of an individual's hip or knee. But how much time someone spends being active is more related to that individual's beliefs and attitudes. So the first thing that I did as part of my PhD was to undertake a literature review to try to find if there were any interventions that successfully encouraged people to be more active after their joint replacement. So as of July this year, there were 7 published trials in the area. 5 looked at interventions that targeted changing behaviour, and these included motivational exercise counselling, interval walking training, wearing a Fitbit, education sessions about the benefits of increasing physical activity, as well as exposure to high intensity exercises, and telephone health coaching, plus or minus paying people when they met certain physical activity targets. And then there were 2 trials that evaluated non-behavioural intervention, and these were looking at different surgical approaches for total hip replacement surgery and additional physio and OT sessions during their inpatient rehab. The results of the systematic review, well, we were mainly interested in the results of the behavioural intervention studies, and the meta-analysis that we did showed non-significant positive effects when measuring active minutes per day, daily energy expenditure, and daily steps. And I've got 2 of the meta-analyses shown in this table here, and you can see that the results are trending towards favouring the interventions, but the confidence intervals don't cross 0. Sorry, I beg your pardon, they cross 0, so they don't achieve statistical significance. However, it gave us an indication that behavioural intervention, if done well, offers promise in improving physical activity levels. The one important thing that I took away from the systematic review is that the intervention has to be done really, really well to have an impact. Just saying to people after a joint replacement, please move more, it's good for you, it isn't enough. So where do you start trying to solve a problem like this? Well, we started with looking at something that we were already doing here at the Angus Community Rehab Program where I work at Eastern Health. Although the evidence is quite limited, it appears that most people worldwide have their joint replacement rehab on a one-to-one basis with their therapist, whereas we tend to use a lot of group therapy to deliver our rehabilitation. And we wondered if the group environment had an impact on self-reported physical activity levels in the early stage of outpatient rehab. So I've modified this slide a little bit from what was published just to make it look a little bit easier on the screen. So what we looked at here was self-reported physical activity and functional measures when people began the group, when they finished the group, and the group was ran for 6 weeks, consisted of once a week therapy for an hour. And then we evaluated them 6 weeks after the group had finished. And we found that there was some significant changes in physical activity when people were attending the group. But these changes, it was interesting, other functional measures followed a similar pattern, but walking ability, measured by 6-minute walk test and 40-metre fast-paced walk test, continued to improve after the group discharge. So it was really interesting. Physical activity was not related to walking ability. So where to from here? Well, our plan is to conduct a qualitative study next to find out from people who have had a joint replacement how important physical activity is to them, their knowledge of physical activity's impact on health benefits, and what can be added to rehabilitation programs that encourages physical activity. We're then hoping to use these results to inform a randomised controlled trial with the aim of identifying an intervention along with dose and timing effective in increasing physical activity after joint replacement. And that's it. Thank you very much.
Thanks very much, Linda. Unfortunately, I think we've actually lost Sam. So our tutoring's actually gone missing. So at this stage, what I'm going to do is take over as chair. I'm going to open it up to everyone to ask questions. So if you've got any questions for each other, and attendees also have some questions, you're welcome to ask them. Yeah, go ahead.
Just one comment. You're quite soft, Michelle, so it's quite difficult to hear you.
Oh, I see. Sorry. Is that better?
Yep. And I guess I've got two questions. One is for Nadia. You mentioned social structural factors. I just wondered if you can elaborate on that. I didn't really understand what that meant. And the second question I've got is for Jason. You might have touched on this, I might have missed it, but what sort of data are you using? Because you're sort of like trying to quantify a lot of costs and outcomes, but I know you touched on smart registry, but there's limitations in terms of what sort of costs you can capture with hospital records and within the smart registry, but maybe you can elaborate on the data sources that you're using. So.
Sure, I'll go first. So socio-structural factors relate to anything in the person's social context. So a lot of the time what we're seeing in this group of people is that they're gauging their response based on their social interactions and people around them. So people who have gone to, say, rehab or something like that, they're gauging how good they are compared to their peers a lot of the time. So if they're seeing other people in pain, suddenly that's normalised and that's okay. Other social factors are people like immediate networks, so the social support that they have around them. So people who tend to have more friends and family members interacting with them and participating more in social events, they tend to be a little bit more satisfied as well. So it's anything within that social network and social context that affects people's satisfaction, really. Does that answer your question? Is that better? Cool.
Now, in terms of the costings data, what we're going to do is we've got some data from the Decision Support Unit at St. Vincent's Hospital, and that's essentially a database of what the hospital ends up paying for each service, including staffing costs, rehabilitation, ICU prostheses, so on and so forth. So that's essentially all from the hospital side of things. And it's a similar sort of data set that Trish Pule used in a paper a few years ago. So I don't have that data with me at the moment, but it's all from the hospital's Decision Support Unit.
I suppose if you're trying to quantify the cost towards the entire healthcare system, well, I guess just with hospital data, you're only able to see it from just the health, sort of like hospital perspective. So that kind of narrows your perspective a little bit.
Yeah, that's correct. So at the moment, that's sort of the base that we're starting off, just get a sort of at least one perspective. We're going to have a chat with one of the other colleagues to see sort of what other elements we should be including to see how comprehensive we can actually go in terms of capturing the data and whether that would actually significantly alter the cost as well. Because a lot of the costs that we're assuming are going to be in the first sort of 30, 90 days, and most of that will be from the hospital side of things, especially in terms of inpatient bed days and prosthesis. There's other additional costs, including prescriptions, outpatient appointments, so on and so forth. We don't really know how much that contributes, but our assumption at this stage is that it's not going to be a significant amount, but it's certainly something we'll be looking at down the track as well.
Yeah, because I understand the translational team, or at least with the Smart Registry, they are trying to link the Smart Registry with PBS and MBS data, like what Sean is doing. So potentially that's a good source, which I'm hoping to tap into as well. So
hopefully sooner rather than later. That would be interesting to see what additional costs incurred outside of that as well.
Yeah. Okay. Thanks.
Excuse me. I have a question for Lyndon, actually. And I really like your PhD topic. I think it's really interesting. And I just wondered as well, and I know you haven't started the qualitative stuff yet, but whether you had any idea as to what you think that the intervention will be that you try and roll out down the track, whether you have any kind of ideas.
Well, that's a really good question. Some of the interventions that came up in the systematic review, I thought were going to absolutely nail it. There was one in particular that came out of the States where they had a really in-depth education sessions, as well as actually experiencing high-level intensity. So they put them on the treadmills and put them on the exercise bikes and gave them heavier weights, you know, longer than what they normally would. And even then, the results came back as no difference. The problems with the interventions that have already been looked at was, I think, the timing of the interventions, because all of them were at least 6 months or 3 to 6 months down the track. And so I think by then you've already got a chance for these patients to have embedded and entrenched these sedentary activities after their hip replacement or joint replacement. So I suspect that actually getting to them sooner is going to make a big difference. The other thing is looking at the fidelity of the treatment. And when you looked at the 2 motivational interviewing studies and the motivational counselling studies that were actually done, if you looked at their methodology, they didn't quite adhere to what motivational interviewing methodology should be. Does that kind of make sense? They missed the mark on just a few things, like the intensity and how much time they spend within the motivational interviewing process. So I think, again, looking at the fidelity of the intervention that you're delivering, are you really delivering what you say you are? I think those 2 are going to be the big things. But exactly what form that takes, that's the exciting part, and I really not quite sure exactly where that will take us. It will depend on the qualitative study, because I intend on asking them exactly that, like what could be added to the rehab that you experienced that would encourage you to be more active. So actually getting people's ideas who are in that situation to say, yes, if someone had done this, I would be more active. Have a go.
Very cool. Thank you.
I just have a follow-up question to that, Lyndon. It's about your qualitative, the qualitative component of your study. Are you concerned about the physical literacy of these people? So do you think there's any potential that you ask them what would they like to do, and they kind of go, I have no idea because I've never exercised for my life?
I reckon that could be a big point, yeah. So finding out exactly how, I think the other thing is finding out how important physical activity is to these people. It could be very, very low on their list. And when we're talking physical activity, we're talking about meeting these physical activity guidelines, you know, the 24 minutes a day, 150 minutes a week, etc. It could be that, oh, you know, my knee's feeling better, my hip's feeling better. I just want to be able to get up to the fridge and grab a tinny without feeling, you know, the pain that I used to. I want to just walk the dog, or I want to, you know, take my grandkids to the park. They're not actually thinking about being active for a specific amount of time. So I think we'll find very low health literature or activity literacy around the actual recommendations.
Yeah,
I think that their physical activity levels are probably deeply entrenched by the fact that they've been in pain for quite a long time, and they just have got into the habit of not moving, and that habit perpetuates after their replacement.
Could this maybe inform like an educational component to your intervention, where they understand why they need to exercise and what exercise is?
What exercise actually is.
Yeah.
That's right. And so we need to ask them, okay, so what do you want to know? And how do we ask it in a way that people are actually going to take notice of it?
Yeah. Yeah. Cool. It's cool. Very exciting.
I want to apologize to everybody. I had a at just the wrong time. Linda, I'm sorry I missed the end of that, but I will jump on YouTube at the end to catch up on the recording to hear the rest of it. So please, were there any other questions? Discussion? I was just going to ask a very generic one that I wanted to ask to get conversation going. But Sham, you touched a little bit on some of the challenges that you'd encountered with your data linkage. And I wondered if everyone could maybe reflect on one of the challenges that they'd encountered so far, and maybe anything that how they had overcome those challenges. Any gems or pearls of insight that they could share with us. Tara's got her hand up.
Oh, yes, I'm unmuted. Technology issues. So the inertial measurement unit system that Jay and I are using is a work in progress. But it's good because we're learning lots and lots about problem solving and thinking on your toes. But yeah, it's a little bit frustrating when you feel limited by something that ultimately is quite out of your control. Yeah.
Yeah, I can imagine. And there's nobody that's used this before? Can you draw on?
Yeah.
Not this version.
Not this version as well, but we've got some pretty smart people surrounding us that seem to be able to have the right conversations with the company. And it's happening. They're really great. They're making changes as we go, but it's always a little bit scary when you're collecting data that you're not really sure of.
Yeah, and when you're working within a timeline too of your PhD.
Yeah,
Is
exactly.
that a timeline?
No, I think I'm okay because I think as long as my data is collected by the end of the year or early next year, and it's not, I should say, it's not affecting me collecting data. It's just that it's all a processing thing. So, so the data should be okay. We hope. I won't know until they can figure out a better way to process it. That's kind of the scary part, I suppose, as well. Yeah.
Anyone else? Anyone else have any challenges? Nadia, big systematic reviews?
Yeah, I guess that has been a challenge. Yeah, we've been working on this systematic review since, I guess, around March last year, and we've been rejected twice from publication, which is, yeah, very disheartening. And what that means is that the systematic review is out of date, so we've had to rerun the literature search, which is very painful, and go through that exclusion criteria again. So I don't know how avoidable that is, though. I guess if it gets rejected, it gets rejected, and just take on the feedback as best you can. But I would say as a positive out of it, I've become very good, or not good, but maybe a bit quicker at reviewing articles and doing a risk of bias screening. So that skill has improved, I guess, as a positive out of it. But yeah, it's been very tedious, and I've felt many times that I just want to burn it, but it's okay. Hopefully done soon.
That's a good point, though. I think with systematic reviews, there is that timeline a little bit that you have to work towards, because if it will go out of date and you will have to renew it. And so I think that is a good little gem to share with everybody that might find themselves in a similar situation. Being rejected from journals, that's certainly part of the process. But as far as, yeah, the timeline for systematic review, it's a good thing to keep in mind, I think.
Yeah, a bit more time sensitive than another kind of publication. Yeah.
Absolutely. Yeah. Who else? Anyone else? Jason? Have you had any challenges that you've incurred along the way so far? Oh, we need to unmute you. Can you unmute yourself?
Yeah, I think the main issue is just going across the literature because it's so broad more than anything else, trying to find out sort of what is relevant and what's not. And you end up sort of going onto a tangent sometimes where you read a paper and then you find something that's interesting, sort of relevant, and you go on. But it's sort of just like focusing back in on it. But at the end of the day, I think it's just one of those things where it's like a marathon. You sort of just keep at it, keep yourself on track, and every now and then just sort of step back, take a look, see where you're at, and just try and refocus until you get there. Yeah. But I suppose there's no easy way of going about it, because I think just having that sort of set structure.
Can you remind me what phase of your PhD you're in?
Starting in Feb, yeah. So probably about 8-9 months in now. Yeah.
So have you had confirmed your candidacy? And
no, so that's due sort of in about 3 months. I think looking at sort of Feb next year at that stage.
You're still in the exploratory phases, really.
Yeah.
What about you, Michelle?
I guess for me, with the first piece of work that I did, it was more of the statistical analysis interpretation of results. I suppose it's not really my strong point. So it was difficult for me to try and interpret the results or understand what they mean, and sort of like technical stuff in conducting survival analysis and that kind of thing. And I know now Sham has, skill set in that. I could probably ask you for advice next time.
Hopefully I can help. Yeah.
Yeah, but that was the challenging bit for me. But fortunately, I've got loads of colleagues that sit around me that are really good that have a lot of different skill sets that I can tap on. So that was really useful for me. But that's something that I found challenging. It's just trying to different techniques of analyzing and interpret the data. I suppose that was tough. Yeah.
Mm-hmm. And those colleagues are around you. Where are they physically around you? Within the areas, you mean? Or?
Sorry?
Is that within the 2 CREs that you're involved in? Colleagues that you can draw on for their assistance?
So I usually sit in the health economics unit at the Center for Health Policy here at the University of Melbourne. So I've got colleagues around me that are from the health economics unit as well, and the Center for Mental Health Policy, Mental Health, Center for Mental Health. So everybody kind of has quite different backgrounds, which is useful for me that I can draw on. So they are sort of like research fellows, or some of them are PhD students. So just a variety of people. So I actually work across 2 different CREs, but I don't actually necessarily physically sit with them. But I guess I do get the sort of like the advantage of going to sit with them whenever or sort of like utilize the resources that they have in a way, which I guess I should tap on as well.
Absolutely. And of course, everyone needs to remember too that we've got the Education and Training Subcommittee in the CRE as well. So if there is a particular methodology and there's somebody within our broader group of researchers that might be able to help you with that, then that's something you can flick to our subcommittee a question saying, look, I'd love a session on this. And we can certainly draw on that web of people to help out.
Okay, great. Thank you.
I think we had a question there for Tara, is that right?
Me, yeah, for me, from Daniel.
Okay. Can you see it there, Tara?
I can, yeah, if I pull up my Q&A. Yes, I can. So Daniel's asking me about this, the confidence question, and saying, is there a more comprehensive list of questions assessing confidence, for example, in low back pain, which you could potentially use for total knee replacement patients? Or will you need to start from scratch when developing a questionnaire? Yeah, and actually developing a questionnaire on confidence is hopefully something that I'll be able to do after my PhD. I was thinking about it maybe as a nice little postdoc project, but we'll see. But that confidence question actually comes from ACL literature. So it's from a questionnaire on ACL, returning to sport, I think, in ACL, or quality of life, ACL quality of life questionnaire. And it's pulled straight from there. And it's the only one in the course that actually addresses confidence at all. So I think what we would plan to do is to have a look at the themes that emerge from the interviews, and then hopefully use them to be able to put together some sort of questionnaire that covers more aspects of confidence, and hopefully get a better understanding. Because I think one question is really tricky when it's such a broad topic as well. I also think it's probably quite highly related to fear as well. And so I've been asking participants a bit about fear in my interviews as well, asking them if they're scared or they're fearful of their knee. So that could be another kind of topic that's quite linked.
Yeah, great. Thank you.
No worries, Daniel.
Okay, well, Lyndon, if we go back to that other question that I just had there, I'm interested in what you've, how long into your PhD, sorry, are you?
Hi, sorry, you talking to me, Sam?
Yes.
Yep. I started my PhD in May of last year.
May of last year. Okay, so you're a little bit
very part-time.
Right. Okay. So tell us a little bit about one of the challenges you've had along the way.
Oh, the challenges. Oh gosh, because the biggest challenges I've had are learning how to use new programs, like things like SPSS, RevMan, and all those sorts of like programs around the methodology and putting together like the right answers for your research, and that I found is really hard, just not being familiar with the programs and having to learn them from scratch. And then was said, when you have to, like Nadia said, when you have to go back and redo your systematic review, it's like, oh gosh, how did I do this again? How did I get, so that's probably been the hardest challenge for me, is just like getting my head around the computer side of things in many ways. Fortunately, I'm supported by an amazing team with Nick Taylor and Nora Shields and Michelle Dowsey and Peter Chung. So I've certainly got a lot of great people to fall back on when it comes to asking particular questions. But then when it comes to just doing it on the computer myself, that's where I found the biggest challenge.
And, but time consuming to invest that time at the start, but certainly saves you time down the track, doesn't it? Worth the investment.
Yes, if I can remember how to do it, it certainly does.
Absolutely. Sean, what about you? Is there anything else that you've struggled with? You talked a little bit about ethics. I think that's...
Yeah, I think also, so in addition to getting the data sets and linking them, the challenge for me has been understanding the clinical context, because I don't have a clinical background at all. So I'm coming at this from purely a statistical, mathematical kind of background. So learning what the words mean and what's going on in the osteoarthritis space has been a bit of a challenge, but really interesting at the same time. And I think also, just to touch on something similar to what Tara was saying before with data and not knowing what exactly is going to be in there and what exactly you can do until you get in and get into the data. That's definitely also a big concern of mine. And I think, PhD or no PhD, when you're dealing with data, there's always limitations that you find out when you actually get in there. And there's always, things that perhaps you have to sort of think of different ways of doing them. So I think that's definitely gonna be the case later on. And I think the positive from that is, from a statistical perspective, it's probably an opportunity to be a bit more innovative in terms of what I do with missing data, for example, or inaccurate data, etc. So I think I'm trying to see it in that kind of light and read, I guess, a bit more broadly in terms of how to deal with this type of data should issues arise.
Yeah, no, that's really interesting. An opportunity to be creative, it's nice. You're the only one without a clinical background, I suppose.
Yeah.
We've had today. It's interesting. Jay, I think you're the only one we haven't heard from. What can you add? These challenges, your early days still.
Yeah, so I started on January 1 and my candidacy was accepted in July. So kind of 6 months in really to actually collecting my data and being on the project. My PhD is somewhat difficult as I'm embedded in 2 different NHMRC grants and 2 different projects effectively, and they're crossing different PhD projects as well. So Tara and I share data, and I'm collecting some of her data on the case series. So some of the logistics there is a little bit difficult. More around the case series though, I've currently got 5 out of 8 people running through the case series. And the case series is quite intense. With the baseline period and the intervention period, we need to have weekly measures taken, just with their questionnaire data. And that is quite burdensome on both the person running the project, me, but it's actually more burdensome, I think, on the participant who's having to remember to complete it and whatnot. Once they get to the intervention period, hopefully that becomes a bit easier for them because they're actually seeing some benefit, but there's this 8-week baseline where they're not getting anything. And some other issues in this population might be that they tend to be a bit older and have multiple comorbidities. I've had one person who's been needed to be admitted to a facility to get their medications checked for some psychological conditions they have. I've got some other people, 2 other people who've had cataract surgery in the meantime during their baseline period. So trying to negotiate how all of that works and if that's a problem for the study is also quite interesting. Later on for study 1, where we're trying to use a pattern matching program, I'm seeing there being issues there, where I have zero technical experience with computers and coding and software. So we're going to use this Curtin Innovation Center, who are actually there to support us for that. And they'll be doing some form of computer-based learning to maybe try and help me with my my ability to answer the questions that I have. So yeah, we'll see how that goes. I'll probably have more problems in the next 6 months than I have already.
Yeah, you have already.
Yeah.
Oh, that's excellent, but good support around you. And I think that's a really nice point too, that you know, a clinical trial like that goes on in the context of life, doesn't it? Everything else.
Absolutely.
So they make them a challenge.
Yeah, it's definitely a consideration for if they're going to use this population with such an intense intervention in an RCT, for instance.
Sure. Yeah, absolutely. Okay, we're getting towards the end of our time. Is there anything else that anyone would like to talk about before we wind up? And of course, we can all be in touch with each other by email afterwards to continue any discussion or questions that you might have and like to pose privately. Is anyone else raising a hand, maybe? No? Great. Well, we might tie it up there then, everybody. And to say thank you very much for all coming and presenting your work today. It's a great body of work that we have here, and we can see the diversity of skills that we can all draw on is certainly really exciting. So, as I said, if there's anything that the Education and Training Subcommittee can help you with or support you in any way, then please do let us know. You can flick me an email as chair or Anne Smith as co-chair. We'd certainly love to hear any suggestions that you might have of areas that you'd like to get some support in. And in the meantime, I wish you all a lot of luck. And I think the next session that we're going to have in this group, we'd also like to have an early career researcher group too. So myself and the 3 other postdocs would like to also present some of our work and do a similar sort of session to what we have today. So stay tuned for that session as well sometime in the future. So thank you very much, everybody. And looked like we went off without too many IT glitches, except for my end. So well done, everybody else. And thank you for your facilitation.
That's all right. Thank you very much, Daniel, for staying with us, as I've written in the comments. Good luck for your exams.
Great.
Great.
Thank you. Thanks for having me.
Thanks, everyone.
Thank you.
Cheers. Thank you. See ya.
Bye.